Good evening, friends. I'm back. Today, let us discuss male infertility, assessment and management. Thank you for logging in on a Sunday evening. Let's not waste time. Straight away jump into the topic. The preamble to the topic is that male factors alone account for up to 30% of subfertile couples undergoing IVF. Maybe due to problems with sperm production or transport or deposition, that is sexual dysfunction. The underlying cause in most cases is idiopathic. To set the tone of the talk, what I want to tell you right in the beginning is that modifiable lifestyle factors can have an impact on male fertility. But medical treatments have a limited value in enhancing semen quality compared to the medical treatment for female infertility. Most treatments are based on assisted fertilization techniques. So now you know the climax actually, or the secret of treatment, or what is going to come up. We don't actually treat the underlying cause because it is very difficult. We would rather take shelter under assisted fertilization techniques as far as male fertility is concerned. Before we go further, we need to understand the spermatogenesis. Spermatogonia, which is in seminiferous tubules, they undergo mitosis and become primary spermatocytes. Then they undergo meiosis 1 and 2 to become spermatid. And they have a spermiogenesis process, because of which they become the mature sperm. That means they lack their cytoplasm and will have condensed DNA in the unit head, an apical acrosome, and a tail. The whole process takes 3 months. This is very important for us to understand, because when we advise individuals on the potential effect of lifestyle changes on semen quality improvement, we have to wait for 3 months. Nothing can be magical. Suppose somebody says within a week your sperm count will go up. Should not believe that. Hormonal control of spermatogenesis is very important, like in case of oogenesis. Here also, FSH is required. FSH binds to Sertoli cells and increase spermatogonial number and maturation to spermatocytes. But it is unable to complete spermatogenesis alone. So it requires LH, something like 2-cell and 2-gonadotropin theory in case of females, wherein the LH encourages theca cells to produce androgens, and granulosa cells will convert that into estrogen under the influence of FSH. So LH is necessary for testosterone production by the Leydig cells, which are akin to theca cells, and plays an essential role in spermatid maturation. So you need both FSH and LH, even in men. This is important to understand. Suppose there is a treatable cause, then there is a case to give FSH, LH in men also. What are the causes of male infertility? When we talk about female infertility, we talk traditionally ovarian causes, tubal causes, uterine causes, cervical causes, and things like that. Here, in male infertility, we talk about or divide, classify, categorize as pre-testicular, testicular, and post-testicular. What are the pre-testicular? Like we say HPO axis, here also they are under the masters of hypothalamus and pituitary. So hypothalamic disease can give rise to male infertility, such as Kallman syndrome, where there is impaired sense of smell. Pituitary diseases also can cause infertility. Pituitary insufficiency, either because of tumors, trauma, radiation, or surgery. Hyperprolactinemia. Please recall my talk on hyperprolactinemia. It will cause problems in females as well as males, especially the adenomas. The levels are same for investigation. Exogenous hormones, anabolic steroids, glucocorticoids in excess, hormones for hyper or hypothyroidism, all of them will cause male infertility. Testicular. After pretesticular, we come to testicular. Congenital problems. It could be genetic, as in case of Klinefelters, which is 47XXY. It's a chromosomal problem. They will have oligospermia. Y chromosome microdeletions, Noonan syndrome, and other congenital problems such as cryptorchidism. If the testes are in the inguinal region, they will be not useful at all. Maybe after some time, they may have to be either you have to do orchidopexy, but most of the time they don't work and they may have to be sacrificed. Acquired testicular causes could be injury. Injury can be due to infections like orchitis. Mumps is the notorious one, or it could be torsion, which apparently occurs more often than we think, and trauma. Varicoceles. I'm going to talk in length about varicoceles, so right now let me not waste my time. Systemic diseases like renal failure or liver failure, they will also affect the spermatogenesis. Chemotherapy. The oncofertility is not only for females, but also for males. Radiotherapy, like they destroy the ovaries, they can destroy the testes. Testicular tumors will totally destroy the testicular function. And finally, the famous idiopathic. Post-testicular. Post-testicular again is divided into those because of obstruction, congenital, cystic fibrosis, congenital absence of vas deferens, Young's syndrome, or it could be acquired like vasectomy. Sometimes men hide that. They would have undergone vasectomy in the previous marriage. They get remarried and they won't like to tell that to the next wife. Infection, chlamydia, gonorrhea can destroy the vas, or iatrogenic vasal injury, as you are trying to do some other surgery, herniorrhaphy or hydrocele repair. You may injure the vas. Post-testicular can be disorders of sperm function or motility, not just the transport of it through the vas deferens. Immotile cilia syndrome, that could be one of the causes. Maturation defects, immunological infertility. This has a very big impact because that's what my Professor Kaulgud used to say. He was pro-women, being a gynecologist and one of the greatest gynecologists, and because of whom I actually took up gynecology. For everything, he was pro-women, but except for sterilization, he always advised vasectomy. I was expecting him to advise, rather he was advising tubectomy. I was expecting him to advise vasectomy. The reason he gave was that if you do vasectomy, there will be some immunological effect on the sperms. And even if you reverse, they will remain infertile. Whereas if you reverse the tubectomy, we have seen good amount of conception happens. The percentage is almost similar to IVF percentages. So that is why probably immunological infertility has to be understood. Globosospermia. Then finally, sexual dysfunction, which includes timing and frequency. For all you know, they may not be having a proper timing of the intercourse. You have to have intercourse when the egg is around. Or frequency. Maybe they are having in a wrong time and in a wrong frequency. Maybe they are away. Erectile and ejaculatory dysfunctions. This plays a big role in deposition of the sperms in the right place, right time. Diabetes, we all know diabetes can cause impotency. Multiple sclerosis does the same thing, and spinal cord and pelvic injuries. So it's very simple, actually. If you sit quietly and think of it, you will get all the reasons. Pre-testicular, nothing but hypothalamus and pituitary. Testicular, you have to think of congenital and acquired problems that can happen to the testis. And post-testicular, of course, is the question of transport to the vas and to the immotile sperms, and then finally the deposition of the sperms. So it's very simple. There's nothing to by heart here. What is important to understand is that more than 50% of the cases, we don't know what is the cause of it. There is no cause that is identified for oligospermia. That's the challenge in every single disease. So the categories of female infertility, we have seen the causes in one way, that is pre-testicular, testicular, and post-testicular. But if you have to categorize, like while I was talking about primary amenorrhea, I first categorized in terms of FSH, hypergonadotrophic or hypogonadotrophic and normogonadotrophic. And then I changed it to clinical variety, feminization or defeminization or masculinization. Then I spoke about the anatomical levels. So similarly here, I first talked about pre-testicular, testicular, post-testicular. Now I categorize it in a different way, that is endocrine and systemic disorders. They constitute 2 to 5% of the cases, usually related to or secondary to hypogonadotrophic hypogonadism. That's, after all, is the endocrine and systemic disorders. It could be hypothalamic causes, which I mentioned. Kallman syndrome could be the cause, or prolactinemia, hyperprolactinemia, thyroid, and others, including diabetes. Other way is primary testicular defects in spermatogenesis. 65 to 80% of the time, this is the cause, of which the majority have idiopathic dyspermatogenesis, an isolated defect in spermatogenesis without an identifiable cause. This is the toughest one to treat. If there is hypogonadism, probably, or hypogonadotrophic hypogonadism, you can inject with FSH-LH. Or you can even give clomiphene citrate, like we give in case of females. But if there's a primary testicular defect, this is the one which is very difficult to treat. Sperm transport disorders, 5%. So as I said again, even if you do a beautiful recanalization of the vas, already there is some autoimmune problems, and this may not be very successful. Idiopathic male infertility, 10 to 20%. Again, this is the tough area. So just putting down everything in a table, I'm not going to explain this again. Endocrine and systemic disorders, which is nothing but hypogonadotrophic hypogonadism. Congenital disorders like Kallman syndrome, iron overload syndromes, multi-organ genetic disorders. Acquired, whole lot of them, like pituitary microadenomas, hypothalamic infiltrative disorders, and hypothalamic lymphatic infundibulitis, head trauma, vascular, that is pituitary function or aneurysms, hormonal, as I said, whole lot of hyperprolactinemia, androgenexis, estrogenexis, cortisol excess, and drugs. Then to continue, systemic disorders like severe systemic illness, nutritional deficiencies, morbid obesity. And then comes the primary testicular defects, and they have congenital disorders like Klinefelter's, cryptorchidism, myotonic dystrophy, androgen insensitivity syndromes. Acquired varicoceles, infections, drugs, environmental toxins, immunological disorders, trauma, and testicular torsion. Systemic illness also will affect the testicular defects, idiopathic renal failures, hepatic cirrhosis, cancers, etc. And then the genetic causes like Y chromosome microdeletions, autosomal X chromosome defects, mutations. Finally, the sperm transport disorders like epididymal dysfunction, abnormalities in vas deferens, seminal vesicle and prostate ejaculatory disorders, sexual dysfunction, and idiopathic male infertility. So whichever way you look at, you have to understand this Mainly, it is pre-testicular, testicular, and post-testicular. You can describe it any which way you like, but you can write a good answer with this, I hope. The age, we all know in case of females, it's a very small window between 10 years to 45 years in the reproductive age group, what we say. Only then they can reproduce. As we understood in the basics classes, that is biomarker classes, from 400,000 oocytes, only 400 are secreted or rather ovulated in a lifetime. It is not like that in men. Men can produce sperms at any age, even at the age of 96, but the fecundity is not the same. Paternal age more than 35 years halves the chances of achieving a pregnancy compared with paternal age less than 25 years. The effect of age on male fertility is more noticeable after the age of 50, with concomitant increase in adverse outcomes in the offsprings. Something like after the age of 35, we say Down syndrome is very common in case of females. Similarly, here also, if the male age is more than 50, then you can expect anomalies. So that's exactly why we tell both male PGs and female PGs, you get married early, everything has to happen simultaneously. You have to do post-graduation, you have to marry, you have to have children. I got married just before joining for post-graduation, and I had a child when I was just in the final years. So everything has to be done in life. You have to just give priorities. For this reason, the age of semen donors is limited to 40 or 45 in some countries. Now you know why we cannot take sperm donors more than the age of 40. Varicocele, I promised you to talk in detail about varicocele. A collection of dilated refluxing veins in the spermatic cord found in 25.4% of men with abnormal semen. That's okay. But here comes the surprising statement. 11.7% of men with normal semen also have this varicocele. Now you decide yourselves whether they really matter or not. The exact mechanism by which a varicocele can affect fertility is not well understood, but theories include. I remember jokingly, my professor used to say, if you are a urologist, you will say varicocele is very important. If you are a gynecologist, you will say that's not at all important. Probably that's it. Increased scrotal heating may be the cause. Altered testicular thyroidogenesis may be the reason. The diagnostic significance of varicocele is, in any case, debatable. Also it's surgery on varicoceles. There is definitely an increase in the sperm count, but we don't know the quality and whether it converts itself into pregnancy. As it is, if you do semen analysis, it should be done once in 3 months, actually. I'm going to come to that. In a normal person also, it varies from one analysis to another analysis. So that's why sometimes what happens before the varicocelectomy, you would have done one analysis, and incidentally or luckily, the next analysis may show a higher thing and you can take the credit. Same goes with the other drugs also. I'm not just telling the varicocelectomy, about the drugs also, the same thing is going to happen. Diagnostic approach. So having understood all these things, the initial evaluation is focused on detecting the small percentage of causes that can be treated to restore normal fertility. You remember right in the beginning, first and second slide, I told you it's very difficult to treat male infertility, but there is a small number of cases where you can find out a cause which that can be treated, and our approach is that only. The remainders is focused on determining which couple with male factor might benefit from ART. I would put it as most of them. Diagnostic approach, the initial visit, you have to take a good history, keeping in the mind all that I told. Physical examination is important to see whether the testis is in its place or it is in the inguinal region. Its a size, everything has to be noted. Semen analysis is very important. Additional evaluation would include endocrine testing, select cases, not everybody. Imaging of accessory glands and ducts, if you suspect any microadenomas and things like that. Genetic testing, very, very small percentage of cases where you suspect Klinefelter's or other syndromes. Fertility history is very important. Previous pregnancies with current and previous partners. That's what I told you. Suppose the person has produced children with the previous partner. That means probably that time it was fine. Maybe something happened after that. Or if he has not produced with both the partners, then it's another story. Duration of infertility is very important. The long standing or a short standing. That would suggest whether the problem was recent origin. You should ask history about whether he underwent any surgery or any damage, any infections that would destroy the testis. Previous infertility treatments, if any, he has taken. Usually they would have gone to many people and they would have taken a whole lot of treatment, including from the quacks or the roadside dealers. Sexual history, erection or ejaculation problems. If there is any dyspareunia, superficial or deep dyspareunia, for all you know, there may be sometimes just a phimosis. And in females, I have seen just a tight, introitus may be the cause, or you have to just do a crucial incision and then everything would be fine. Frequency of intercourse is very, very important. Medication history, some of those can cause problems like nitrofurantoin, cimetidine, sulfasalazine. All these things can affect whole lot of drugs, especially the chemotherapy agents and methotrexate in that. Social history, whether the person takes alcohol, smoking. I told you, alcohol and smoking, you will see in every single disease. In spite of that, both men and women choose to drink alcohol and choose to smoke. I don't know why. Anabolic steroids, recreational drugs, exposure to ionizing radiation without their knowledge. Chronic heat exposure. I heard that those who are working in machineries or those even merchant navy, if they're engineers, there's enormous heat there. Those who are working in the in the field, they would be exposed to heat, and that would affect the spermatogenesis. Aniline dyes, those working in the paint industries, pesticides and lead exposure. So a detailed history will tell us whether there is any modifiable cause or it's not possible at all to treat. Medical history, recent pyrexia illness. I already told you that. Systemic illness like diabetes, which can cause impotency, cancer, and infection again. Genetic disorders like cystic fibrosis, Klinefelter's. Surgical history, undescended testis, orchidopexis, hernia repair, hydrocele repair, or testicular trauma, torsion, pelvic, bladder, or retroperitoneal surgery. So a detailed history, including under all these headings, should be taken. Now I come to examination. Height, weight. Klinefelter's, you all know, would be very tall. Weight is important, like in females. BMI is important. If they are very obese, then there will be diabetes. They will be having problems with having intercourse and things like that. Blood pressure, they may be taking some antihypertensives, which may affect in the spermatogenesis. Decreased body hair or gynecomastia suggests testicular feminization syndrome or androgen insufficiency or androgen insensitivity syndrome. Testicular size is important, as I told you. Normally is around 20 ml. There is and consistency should be firm. There is this Prader's orchidometer. Prepubertal 1 to 3 ml. You can just look at these beads. Pubertal is 4 to 12 ml. Adult is 12 to 25 ml. And testicular length, anything less than 3.6 centimeters is considered small. Groin for undescended testes, especially in case of testicular feminization syndrome. Presence and normality of vas deferentia. Epididymis for distension and induration. You have to just palpate and see. Usually what we do in Manipal is that we have good friends in urology department and we send all these men to them and they do a very good job. Varicocele examination, if required, ultrasound also may be done later. Penile, micropenis, hyperspadiasis, and prostatic abnormalities. Everything will affect. So, but coming to the actual evaluation, the most important single first test to be done. Sometimes I would go to the extent of saying only test to be done is semen analysis. First, Important. First, in the sense, both male and female together. This is the first analysis to be done. One sample will suffice if it is normal. Repeat after 3 months. I told you spermatogenesis takes 3 months, so there is no point in repeating within 3 months if an abnormality is detected with or without treatment. However, you may do it sooner if the initial test shows azoospermia, just to reconfirm. Why wait for 3 months? If it is azoospermia, you can repeat after maybe 1 week and reconfirm. But if it's just an abnormality, you have to repeat after 3 months. I hope I am clear about that. Semen collected after 72 hours of abstinence. This we used to insist now, but some books mention you don't have to have this abstinence at all. Analyzed within an hour of collection is very important, and collection itself is a big issue. People say, shall I collect it in condoms? No, you know that condoms will have spermicides. You have to collect the clean, sterile jar from the lab, and you have to take it. Most of the labs nowadays provide a special room for semen collection so that they can immediately give for analysis, because it has to be done within 1 hour. So this is probably the most important slide. Please take a snapshot, or the what you call the screenshot, once I totally show this. What are the parameters? Semen volume 1.5 minimum. See, WHO is so generous. When I was undergraduates, it used to be 120 million and all that. Then it came down to 60. Then it came down to 40, 30, 20. Now it is so desperate. It has become 15. So this also easy to remember. 15 was the count, so it is 1.5 ml. Sperm concentration 15 million. So easy. Volume 1.5 and remove that decimal and becomes 50. Total number is 39. I don't want to manipulate here, make it 45. If I was given a liberty to do that, I would have done, but per ejaculate it is 39. Total motility 40 and progressive motility 32. Actually, I would have rounded it all this for easy remembrance, made it as 30, and upper one I would have made it as 45. So it would have become a table of 15, but I have no liberty. Normal forms 4%. So it could have been 5%, but anyway, they said 4. It's okay, we'll accept it. Vitality 58. They could have made it 60. So everything would have been a table of 15. But anyway, they want to maybe wanted it to be looking more authentic, or there is a whole lot of research that has gone behind it. I should not comment loosely. So what is important here is sperm concentration 15 million and progressive motility, forward motility is 32% and normal forms 4%. These three are extremely important. Now you can take a screenshot of this if you have not taken. Okay. Semen viscosity and volume is very, very important issue. All of you know that semen is a coagulum when it comes out. That is, there is a purpose for that, because if it was not a coagulum, directly if it was deposited in the vagina having an acidic pH, all the sperms would have died instantly. So this coagulum takes some time, 15 to 30 minutes to liquefy itself, so that by that time the semen plasma would neutralize the acidic pH of the vagina and sperms will not die. Such an intelligent nature. So if there is too much of time, then sperms won't come out at all. If the liquefaction occurs too early, all the sperms would die. Low ejaculate volumes, less than 1.5 ml, may not buffer against vaginal acidity sufficiently. So this may indicate retrograde ejaculation, obstruction, androgen deficiency, incomplete collection, or anejaculation. Sperm concentration is very important. Some men with low sperm counts can be fertile. We have not done really a very good research on the fertile men. Only most of the research is on the infertile men only, while others with normal count can be subfertile. That is also possible. For IVF, roughly 10 million per ml or even less can be satisfactory. Lack of sperm in the ejaculate does not indicate the absence of sperm production. So you have to look for retrograde ejaculation, congenital absence of vas, and other causes of obstructive azoospermia. That means there may be sperms, but they are not They have not come out. For few or no spermatozoa per hyperfield, special techniques to increase the sensitivity of detecting sperms in the ejaculate are available. Identifying even few spermatozoa in the ejaculate is useful because it indicates ART might be effective. After all, you need one sperm for ICSI. Morphology, people talk about, that's why they brought in a new term called IMSI and all that, morphologically bigger sperms and things like that. Sperm morphology assessment has modest clinical value. It is useful for detecting selected very rare genetic causes. It has been claimed that morphologic assessment has good predictive value for pregnancy rates after IVF, but these claims are controversial and not well supported by clinical studies. Sperm motility. In general, motility is not an important factor in independently predicting the probability of natural pregnancy unless a very high percentage of sperms in ejaculate are immotile. If you recall, only 4% is good enough. 4% normal sperms and around 30 to 40% motility is good enough. Men with very high percentage of immotile sperms might be treatable with ICSI. That's what I said. You don't even need tail actually. So you can just get the sperm head, which contains the all information to make a child. So in summary, men who have triple defect, what is this triple defect? Low sperm concentrations, less than 15, low percentage of normal morphology, less than 4, and low percentage of motile sperms, less than 40, have high probability of infertility. This is an important slide again. Specialized sperms and sperm semen tests, sperm autoantibodies do not appear to cause infertility. So let us not waste time and money on that. Semen fructose, it's a marker of seminal vesicle function, might be low in men with ejaculatory duct obstruction. But all these are actually not very important in the sense they are needed. Suppose in the natural intercourse, the sperms have to survive. So that's why they are all needed. Semen culture, results are not diagnostic at all. Suppose you find a lot of pus cells, you can send it maybe. Sperm DNA damage, they lack standardization and evidence to support their routine use. So as I said, when I was talking about sperm analysis or semen analysis, that is the first, most important, and maybe the only test that is required for men. Endocrine test, yes, of course, you can do if you suspect there is Sertoli cell syndrome and all that. Just estimation of FSH will tell you if it is very high, you don't even have to do karyotyping, it's Sertoli cell syndrome. FSH, LH, testosterone, prolactin should be measured in men with sperm counts less than 5 million. So if there is hyperprolactinemia, you can treat it. Testosterone deficiency, FSH, LH deficiency, you can treat it. Primary testicular failure means there will be low testosterone, obviously, high FSH and LH. Same as something like Turner syndrome, where ovary is at fault. So pituitary will secrete enough and more of FSH. Obviously, estrogen is less. So here, low testosterone, high FSH and LH. Secondary hypogonadism, which is a central defect. Low testosterone, but low FSH LH also, because it is hypogonadism due to secondary central defect. So something like hypogonadotrophic hypogonadism. Then if it is obstructive cause, there is azoospermia, but normal hormones. That means sperm production is going on, but the transport is not going on. Imaging, scrotal ultrasound, as I told you, for detecting testicular tumors, or you can even detect varicoceles with the use of Doppler. If an absent vas is detected on examination, renal ultrasound is also important because 30% of such men may have renal abnormality. Something like those who have got a Mullerian abnormality, 30% of them will have renal abnormality. Genetic evaluation, as I said, indicated in cases with severe oligospermia, azoospermia, Klinefelters is the biggest example. And CBAVD, congenital bilateral absence of vas deferens, can be associated with cystic fibrosis carrier status. 10 to 15% of men with azoospermia and 5 to 10% of men with severe oligospermia have microdeletions in one or more gene regions on the long arm of Y chromosome. These are not done routinely. Maybe experimental setup it will be done, or if the person is insisting that I don't want to undergo ICSI and things like that, or I just want to have my own sperms, all these tests are very important. Sperm function test, again, not very important. Thank God, postcoital tests are not done anymore. During my PG days, I used to really not like them. It's very difficult to do. Sperm penetration assays, not done at all. You don't have to sacrifice guinea pigs or any other eggs. Hemizona assay, not done anymore. Of limited value from a practical point of view. Not used routinely in clinical practice. Maybe experiment or maybe in research it is done. So now I come to management as per cause. I'm not sure I will have time. If I don't have time, maybe I will combine this with another day. But let me go on as much as possible now. Pre-testicular. Most of these can be treated with hormone manipulation. As I said, if it is low FSH, low LH, then you can give FSH and LH to them. Or you can give clomiphene citrate, which will indirectly get FSH, like in case of females. If it is testicular, it is largely irreversible, but can be treated with ART if sperm is retrievable. After all, I think I will stop the class today. I will talk about the management in another class. I don't want to really hurry up. Thank you very much. See you another day tomorrow.